hereditary, no, up, second one. Gives me up, second one, second, yeah. Excuse me. Can you call the old resident? That's what we have? Okay, I will start. Assalamu alaikum. Good afternoon. Today, our subspecialty lecture is about hereditary alcohol dystrophy. It is a long subject, but it is interesting, and I hope you'll enjoy it and learn something from it. So start with the introduction. The hereditary dystrophy of the posterior segment constitute a large and potentially confusing group of disorders. And if you find on the online Mediterranean inherited in man, this is a very good website in which you can refer it to trigger which retinal dystrophy that we have nowadays. It listed more than 750 genetic disorders with significant involvement of the retina and choroid or both. And also we have another website, which is the RetNet website, lists more than 200 different retinal degeneration in which the chromosomal site and often the specific gene defect have been identified. The causative mutations are heterogeneous with variable presentation, and this is the challenge and interesting things that we are seeing in the retinal and choroidal dystrophy because of different phenotypic presentation within heterogeneous group. So to simplify our topic, let's go for classification. Classification is variable. You can depend on anatomical classification, which is according to the topography of retinal layer, macula, retinal pigment epithelium, choroid, and vitreous. But unfortunately, many dystrophies may involve multiple layers. That's why this anatomical classification may not justify you as a clinician. What about the Mendelian pattern of inheritance by family history? If you trigger the family history, you can't, if you ask about the family history, thank you very much. You can trigger which type of inherited that you are dealing with, whether it is autosomal dominant, recessive, and X-linked recessive, or mitochondria or X-linked dominant by the family history and history of consanguinity. This classification reliable on only 60%. 60% of the family can give you good family history. However, this is not applied in our area, unfortunately, because of the poor history. A negative family history, it is also very important. Why? Because negative family history doesn't say that we don't have inherited retinal dystrophy, but rather than can give you also hint, probably the patients have a de novo mutation. And you are seeing in our practice that sometimes present with hereditary dystrophies with negative family history. Asymptomatic family members also important. If you examine the family members who say that I don't have the symptoms, probably they have some signs that trigger the diagnosis of hereditary dystrophy. Other classification about the phenotypic presentation, and this depends on the diagnostic evaluation by clinical examination, electrophysiological, and psychological testing. And the most important things, of course, the molecular testing. However, the molecular testing also, it has some, not disadvantage, but some limitation. because of varying expression and different phenotypes. Sometimes one gene can give you different phenotypic presentation. For example of autosomal dominant gene, mutation in RDS perforin gene can present with cone rod dystrophy, retinitis pigmentosa, pattern dystrophy phenotypes. So one single gene can give you different phenotypic presentation. Another example, mutation in rhodopsin gene can present with stationary night blindness or retinitis pigmentosa phenotypes. Another example, mutation in the cone rod hemobox containing gene can present with Leber's congenital amaurosis or a cone rod dystrophy phenotypes. Examples for the autosomal recessive genes, ABCA4, which is the common gene we are seeing in retinal dystrophy. It can present with Stargardt disease, juvenile or adult macular dystrophy, retinitis pigmentosa, or cone rod dystrophy phenotypes. So in order to reach the diagnosis, you have to put together the clinical diagnosis and the molecular testing, as I mentioned, because one single gene can present with different phenotypic presentation. So dig on the patient history, for example, onset, so that you can identify this is juvenile or adult. Systemic disease can associate with many retinal and choroidal dystrophy, and also medicine. Medicine can mimic presentation of retinal dystrophy. Family history, as I mentioned, to trigger which Mendelian inheritance, and also to examine the asymptomatic siblings. ERG, or EOG, fundus autofluorescence, OCT, visual field, and others. And don't forget the molecular testing in order to reach the final diagnosis. For example, this table shows the ERG. You can predict which diagnosis depending on the ERG. For example, if you have flat ERG, you are thinking about LCA, retinal aplasia, retinitis pigmentosa, total retinal detachment. If you see abnormal or undetectable photopic ERG with a mild rod ERG, so if it is predominant cone dysfunction by the ERG. So we think about cone degeneration, achromatopsia, X-linked blue cone monochromatism, and X-linked cone dystrophy, and tepto-like sheen. If you see barely or undetectable scotopic ERG and relatively photopic and abnormal photopic B wave ERG respond. So we think about rod cone dystrophy, for example, retinitis pigmentosa, also LCA, choroideremia, chorioretinitis, secondary retinitis pigmentosa, including some storage disease, progressive retinitis punctata albicans. If you have abnormal cone and rod B wave amplitude cone relatively more affected than rods, so we think about the cone rod dystrophy, not rod cone dystrophy. For example, whether cone rod dystrophy, whether it's autosomal dominant, recessive, X-linked, and also we think about the post-inflammatory degeneration. If you see negative wavelength in dark adapted bright flash ERG, A wave is normal to attenuated, B wave does not return to the isoelectrical point, then you think about something which is affecting the nerve fiber layer, ganglion, or bipolar cell. For example, X-linked retinoschisis, congenital stationary night blindness, S-enhanced Goldman-Fabry, and some autoimmune retinopathies. And there is, if you see non-specific abnormalities, then you think about toxicity, metallic phonon body toxicity, chorioretinitis, early panretinal degeneration, partial retinal vascular occlusion, low serum taurine level, and vasculitis diabetic retinopathy. So sometimes one test, it can give you hint of which type of hereditary disease that you are dealing with. So I present with the lecture after this presentation with this classification just to simplify for you and also for me as a presenter. I will classify hereditary and choroidal dystrophies according to diffuse photoreceptor dystrophies, which is including retinitis pigmentosa, LCA, and cone dystrophy. The second classification, macular dystrophy, which is involving the macula as listed down. The third classification, vitreoretinal dystrophy, which is the disease that involve the vitreous and inner retinal layer, and choroidal dystrophy. So let's start with the diffuse photoreceptor dystrophies. The most important one is retinitis pigmentosa. What is the definition of retinitis pigmentosa? It is a typtoretinal degeneration. Some they call the primary pigmentary retinal degeneration. Some they call it pigmented retinopathy, and nowadays we call it rod cone dystrophy. So pay attention, rod cone dystrophy, it is not special form, it is not different from retinitis pigmentosa, rather than it is retinitis pigmentosa itself. So it's a group of disorders that are characterized by inherited, progressive, dysfunction, cell loss, and eventual atrophy of retinal tissue. The initial involvement of photoreceptors lead to subsequent damage of inner retinal layers. Retinitis pigmentosa implies of inflammation by itself. It is retinitis. And why? Because the inflammation is a predominant part of the pathophysiology. The classification and epidemiology. The retinal pigmentosa, in order to simplify it also for you, we will classify it in isolated and secondary. Isolated, which is referred to primary retinitis pigmentosa, which is typical retinitis pigmentosa. It is a hereditary disorder that diffusely involve photoreceptors and pigment epithelium function. It's characterized by progressive visual field loss and abnormal ERG responses. The disease process is confined to the eyes and is not associated with other systemic manifestation. The prevalence is 1 per 5,000 people. And usually this is isolated. It doesn't concur it with any systemic manifestation. The secondary pigmentary retinopathy, which is syndromic retinitis pigmentosa, this is associated with systemic disease, and the prevalence is not well documented. So let's take the typical retinitis pigmentosa. First, we start with the fundus appearance. Number one, arteriolar narrowing and intraretinal bone specule. And you are seeing this in the clinic, that you have typical bone spicules and attenuation of retinal vessels. Then you said this is retinitis pigmentosa. So let's see why we develop this paravascular sheathing and why we have this bone specule. So these pigments represent migration of pigment into the retina from disintegrated retinal pigment epithelial cells with accumulation in the interstitial spaces surrounding the retinal vessels. And this process occurs most prominently at the junction of vessels, producing a perivascular pigmentary cuffing and specule-shaped deposits. And usually, if you have abnormal metabolic things in the retinal pigment epithelium surrounding the blood vessels, it will affect also metabolism of the blood vessels. And that's why probably you will get attenuation of the blood vessels. The loss of pigment within the retinal pigment epithelium produces the gray appearance to the retina with a greater visibility of underlying choroidal vessels. Sometimes you see diffuse choriocapillaris with RP atrophy with prominent choroidal vessels and secondary to degeneration. And eventually, the normal salmon pink color of the entire mid and far peripheral fundus is replaced by dense bone specule pigmentary formation. But remember, sometimes you don't have bone spicules in retinitis pigmentosa, and this is referred in retinitis pigmentosa sign pigmento. It is proven genetically. You see diffuse cortical atrophy, but you will not see the typical bone spicules that you are seeing in the typical retinitis pigmentosa. And as this slide shown, the pale disc, the attenuation of the blood vessels, the beaten bronze appearance of the macula, and the bone specule that's surrounding the blood vessels and all over the fundus. What about the appearance of the optic disc? Earlier, usually you have the golden ring appearance, or what we call or describe like a yellowish white around the disc. And this is secondary to pre-papillary mottling, hyperpigmentation, and atrophy of the RPE. And that's why you will see a golden ring around the optic disc. Usually the optic disc, optic nerve head cup to disc ratio usually smaller, and we say this is like a fullness of the optic disc. In advanced cases, the appearance of the optic disc nerve head pallor pale to waxy appearance. Why? Because some studies suggested because of optic atrophy, and some studies suggested by the gliosis overlying the disc. And some studies, they attributed because of these two factors. Drusen also present in 15%. And this is the study that's done by me and Igor and my co-authors. You can see the pallor of the optic disc related to the Glios is overlying the optic disc and really suggesting the appearing of the optic disc related to the gliosis. And this is published in Grave Arch Clinical Ophthalmology in 2015. So attenuation of the blood vessels, bone spicule. Number 3, macula. Macula can present with a loss of foveal reflex, irregularity of vitreoretinal interface, can have epiretinal membrane, formation of periretinal fibrosis, cystoid macular edema, and atrophic macular lesion. Like in the slide, show atrophic macular lesion. What about the peripheral retina? Peripheral retinal ischemia are common, and periretinal neovascularization also we are seeing in our practice. And sometimes it's described as a coats-like retinal vasculopathy with lipid exudate and serous retinal detachment. As this patient, I have it with retinitis pigmentosa. I follow him for 10 years, and he developed, you can see the exudation, and you can see the ischemic peripheral ischemia. What about the vitreous? Vitreous characterized by presence of cells, which is described as fine, dust-like pigmented cells released from degeneration of retinal pigment epithelium, complete PVD, cotton ball opacity, interwoven filaments in the retrocortical space, and spindle-shaped vitreous condensation. And this is one of my patients which have retinitis pigmentosa, and you can see this white condensation, which looks like asteroid hyalosis and vitreous condensation. What about the anterior segment finding? Cataract, mainly posterior subcapsular lens opacity. The prevalence aged 20 to 39 years is around 52% for autosomal dominant, 39% of autosomal recessive, and 72% of X-linked. So it is very common, the cataract. Keratoconus, also we are seeing patients with keratoconus, primary open angle glaucoma, and high myopia and astigmatism. So this is the clinical features, the fundus and the associated ocular finding. What about the important ancillary tests that you have to investigate for? Psychophysical tests like ERG, perimetry, retinal densometry, dark adaptometry, and imaging modality like fundus, photography, fluorescein angiography, autofluorescein, adaptive optics scanning, laser ophthalmoscopy, and OCT. Let's talk about the psychophysical finding, which is the ERG. So the ERG response in retinitis pigmentosa typically show both A and B wave because we are dealing with photoreceptors loss, which is rod and cone. The B wave are prolonged in time as well as diminished in amplitude. ERG responses may become undetectable. But also put it in mind that undetectable ERG signal is not a diagnosis of RP, not like I mentioned in the previous table. Not every flat ERG, that's when you are dealing with retinitis pigmentosa. And also remember that person with the carrier status of X-linked recessive retinitis pigmentosa show a mild reduction or delay in the B wave response. So this is the typical perimetry of the Goldman visual field. It's present with the mid-periphery scotoma. And then you lose the superior visual field and remnant somehow the inferior field. And then you get just little temporal remnant of vision in the advanced cases. And sometimes even this temporal vision, you can lose it and just you will end with the constricted field. This is the autofluorescein. As you can see, this is the hypoautofluorescein, which is corresponding to the pigments. And you can see abnormal hyperautofluorescein in the macula, which is corresponding to the RPE and overlying photoreceptors damage. And this is the cystoid macular edema, in which the OCT can help you. This is another patient. You can see the bone spicules, and you can see the hyperautofluorescein, which is corresponding to the photoreceptors and retinal pigment epithelial damage. Let's speak about genetics of retinitis pigmentosa. More than 100 different genetic types of retinitis pigmentosa have been identified. 50 genes causing retinitis pigmentosa or similar degeneration, and more than 50 genes causing retinitis pigmentosa has been identified. It can be in autosomal recessive, which is the most common form, which is around 20%, autosomal dominant, 10 to 20%, and X-linked 10%, which is the worst type. The first mutation discovered to cause retinitis pigmentosa were in the gene coding for rhodopsin. And rhodopsin is the visual pigment in rods that mediate the night vision. Negative family history were identified in 15 to 63% of cases. Such cases are labeled as simplex retinitis pigmentosa. Retinitis pigmentosa can show different phenotypic presentation. And what we call regional variants of retinitis can be sector and sectorial retinitis pigmentosa, as the slide show, characterized by pigmentary changes limited to 1 or 2 quadrants, visual field defect usually only in the regions of retinitis pigmentation, relatively good ARG responses, minimal or no extension of the retinal area involved with time. Most cases of retinitis pigmentosa that present in a sectorial distribution are merely the sectorial presentation of what will become, with the time, a more diffuse disease. And sometimes, even in one family, you can have different phenotypic presentation. Like example, this sectorial manifestation of retinitis pigmentosa, you have typical one, and also you have pericentral one. And sometimes even the sectorial presentation with the frequent follow-up can convert to a typical retinitis pigmentosa phenotype. The other regional variant of retinitis pigmentosa is pericentral retinitis pigmentosa. And this is characterized by loss of visual field, typically occurred between 5 and 15 degrees from fixation, rather than between 20 and 40 that we are seeing in the typical retinitis pigmentosa. And you see, this is the visual field. It started with this. Cystoid macular edema, it is common and can present in any genetic form of retinitis pigmentosa. And as I mentioned before, different patterns or a more limited form of disease can be seen in one family. For example, this patient, he presents with a pericentral retinitis pigmentosa, and the same brother, his brother has a sectorial distribution or sectorial variant of retinitis pigmentosa. Unilateral or extremely asymmetric retinitis pigmentosa. For unilateral retinitis pigmentosa usually are acquired. It could be after inflammation, and the most common one to rule out is edushin. And also it can happen after trauma. For asymmetrical retinitis pigmentosa, it can be genetic and can be acquired. For the genetic, the only instant that it happened that if the carrier state of for X-linked retinitis pigmentosa, and also as a genetic trait is through somatic mosaicism of a dominant gene for retinitis pigmentosa. And this mechanism has been reported as the cause of unilateral retinitis pigmentosa in patients with somatic mosaicism of retinitis pigmentosa. So these two entities of genetic disorder in which you can have asymmetrical retinitis pigmentosa. Otherwise, most of other cases are acquired. What about the management? First, support and assurance. It's a teamwork because usually this patient become handicapped and visual disabled. So it's a work between the ophthalmology, doctors, and patient and the family. Low vision aids, it can help somehow, especially for the telescope, to widen the visual field. Rehabilitation and mobility training also, it's important, how to manage in the daily activity with the blind eyes. Ophthalmic evaluation just to see if there's any progression, and also if you see they develop, sometimes they have retinal detachment, they have cystoid macular edema, something that you can treat it as a physician. For cystoid macular edema, you have like carbonic anhydrase inhibitors or diclofenac or steroids. But according to the study and my experience, dorzolamide or carbonic anhydrase inhibitors really work pretty good in CME-related retinitis pigmentosa. The nutritional supplement also have a study with the high daily doses of vitamin A. However, it is limited because of potential systemic toxicity. You can also encourage the patients don't to expose to light so frequently, and by wearing ultraviolet absorbing sunglasses and primed hats, just to protecting from the sun exposure. So, for example, this is a case of retinitis pigmentosa, and he present with a cystoid macular edema. I give him Trosop, and really his macula flattened down nicely. But remember, sometimes it reoccurs, and it can, give continuous, or it depends on the presentation. It's not curable for them. Other modality is by electrical implant that, like what we did in our hospital, the Argus system, which is composed of implant, video process unit, and glasses. And we did till now 11 cases. This is one of the cases that I did. You can see the electronic implant, how nicely aligned on the macula. Some patients get benefit from this implant. Another modality of management is gene therapy. It gives you some promising result, still on trial, and regenerative medicine strategies. So by this, we finished the typical retinitis pigmentosa. Let's go to other example of diffuse photoreceptors dystrophy, Leber's congenital amaurosis. Usually they called severe early childhood onset retinal dystrophy. It's characterized by severe visual impairment or blindness from infancy, wandering eye movement and nystagmus, and usually they have ocular digital reflex in which just want to stimulate some retinal sensation to get some brightness and some flashes. Normal fundus appearance or only septal RP granularity and mild vessel attenuation. Sometimes you have nystagmus and flat ERG with the presence of normal fundus. Also, you have to put in your mind the LCA. Can present with macular coloboma, salt and pepper retinopathy, retinitis, pictures of macular coloboma, salt and pepper retinopathy, retinitis punctate albicans, and immune pigmentation. So lately, or advanced stages, it can present with any form of these listed phenotypic presentation. Cataract and keratoconus are common associated with LCA. ERG responsible typically is indistinguishable. Systemic association was found in 17 to 37, and this is in form of deafness, renal abnormality, infantile hepatic dysfunction, skeletal abnormalities, and neurological abnormality. It finds that the inherited pattern 3 autosomal dominant and 18 recessive mutation. And there is ongoing study about gene therapy, mutation in RPE65, and also giving a good result. Now, I think they are in the 5th year. This is one of my patients. You can see the keratoconus, bilateral keratoconus with the retinal pigmentosa picture. The third example of diffuse photoreceptor dystrophy is cone rod and cone dystrophy. And really, these terms, we can make it together. Nobody will blame you if you said cone rod, and nobody will blame you if you have cone dystrophy, because sometimes cone dystrophy, it tends to go to end with cone rod dystrophy. So it depends on how much cone and rod involvement. So we'll put it as a one syndrome. The onset in the teenager or later adult years is characterized by loss of visual acuity and color vision, hemeralopia, which is day blindness, and photopia, which is light intolerance, with subsequent progressive peripheral visual field loss. This is the typical presentation of cone rod or cone rod reflex. They cannot tolerate to the day light. And also they have some defect in the color vision, because if the primary dysfunction is the cone. The fundus appearance characterized by symmetrical bull's-eye pattern of macular atrophy, mild to severe temporal optic atrophy, and teptoretinal reflex. And sometimes may also normal the macula. Patient with a progressive cone rod dystrophy demonstrate expanding central scotoma over time, and this is, you can see it by the visual field. Latest stages may show bone spicules and also night blindness, like retinitis pigmentosa. All 3 Mendelian inherited patterns and more than 25 gene mutations are found. Optic nerve head atrophy and telangiectasia, high myopia, and macular coloboma are common association. Spinocerebellar ataxia and dental ameliogenesis imperfecta also can be associated with cone rod or cone rod dystrophy. Like this patient, he has beaten bronze appearance, we called it, or teptoretinal sheen of macular reflex, with a templar optic disc pillar. And you can see the nicely corresponding autofluorescent. You have loss of RPE and photoreceptors, which manifests by hypoautofluorescence. And this hypoautofluorescence corresponding to the pigments clumps. And you can see the temporal pair is typical presentation of cone dystrophy or cone rod dystrophy, as I mentioned, according to the involvement of the rod dysfunction. And you can see the corresponding OCT, how thin macula he has. And remember, with thin macula, you'll have a good choroidal detail because of enhancement of the echo that can penetrate all the layer of the choroid. So we finish from the isolated retinitis pigmentosa. So what about the retinal degeneration with systemic involvement, what we call pigmentary retinopathy or syndromic retinitis pigmentosa? The commonest are Usher syndrome, Bardet-Biedl syndrome, Refsum disease, neuronal ceroid lipofuscinosis, Joubert syndrome, and Senior-Lucan. I will speak about the above two, which is the most common one, which is seeing in our practice. The Usher syndrome is the most common syndromic retinitis pigmentosa. This is presenting 18 of retinitis pigmentosa patient. The prevalence is 1 in 6,000. It is autosomal recessive disorder. And the proteins encoded by the mutant genes are part of dynamic protein complex present in the cilia of the inner ear and the cone, outer sigmas of photoreceptors, and that's why you have congenital deafness and night blindness, because the same protein present in the cilia of inner ear is the same as in the cone outer segments of the photoreceptors. The Usher classified to 3 major groups. Type 1, which is childhood onset retinopathy, present with a profound congenital senso-neuronal deafness, severe speech impairment, and vestibular symptoms. Type 2, milder, later onset retinopathy, characterized by congenital, partial, non-progressive deafness, absence of vestibular symptoms. And type 3, the least common, was characterized by progressive deafness starting late in the 2nd to 4th decade. It is adult onset retinopathy and hypermetropic astigmatism. This is one of my patients. You can see the picture of retinitis pigmentosa and the same finding for the autofluorescence, which is caused by damage of RP with overlying photoreceptors and thin macula. The second common one, the syndromic retinitis pigmentosa, is Bardet-Biedl syndrome. The cardinal feature for BBS is pigmentary retinopathy, which is present 90 to 100%. Polydactyly, 75%, in form of syndactyly or brachydactyly, which is present in 14.4% of them. So polydactyly, when you say 75%, 14.4% in form of syndactyly or brachydactyly. Congenital obesity, which is a universal, almost 100%. Mental retardation, 85 to 87%. Hypogenitalism in 15%. So diagnosis at least 4 of the 5 cardinal features that is listed above with the pigmentary retinopathy. You can label it as BBS. It's important to mention in this entity about Laurin and Mon syndrome, which is characterized by pigmentary retinopathy and mental retardation. And paraplegia is the prominent feature without polydactyly or opacity. And some authors, they confuse whether we are dealing with the same BBS syndrome or whether they have a different entity. I mean, the Laurin-Morin is different from Bardet-Biedl syndrome. However, the most they consider the features of Laurin-Mon within the spectrum of BBS. So if you said Laurin-Mon, Bardet-Biedl syndrome, no one will blame you because really it is within the spectrum of the disease. And last study by Beals, he refined the diagnostic criteria like polydactyly, opacity, kidney, eye syndrome, and that's it, without BBS or Laurin-Mon syndrome. The Bardet-Biedl syndrome, how it differs from retinitis pigmentosa? Usually they present with a poor visual acuity in the earlier stages, and usually the fundus show little pigmentary dispersion until later stages. It looks like a retinitis pigmentosa sign pigmento. Macular lesion and atrophy of the RPE or choriocopillaris often develop early and prominently as the disease progresses. Macular abnormality may include macular wrinkling, periretinal membrane formation, and leaking on fluorescein angiography from paramacular capillaries, which is different from retinitis pigmentosa because we don't have leaking in the macular CME in the rated retinitis pigmentosa. ARG may show a rod cone loss or cone rod loss pattern. The onset of night blindness is 8.5 years and legal blindness by mean age of 15.5 years. 73% of patients reach legal blindness status by age of 20 years and 86% by the age of 30 years. So it's really severe disabled vision. Genetics and differential diagnosis of the ciliopathy causing retinal and systemic ciliary dysfunction. Autosomal recessive inherited, multigenic within 2 or more different mutation contribution to the phenotype. 18 causative genes were identified, and the primary function of the protein affected the Bardet-Biedl syndrome are to mediate and regulate macrotubules-based intracellular transport process, and therefore the syndrome we call ciliopathy. And remember, this protein also present in the cilia of inner ear. Differential diagnosis: Alstrom, Senior, Loken, Joubert, Jouen, and Usher syndrome. This is the type of ciliopathy that you have pigmentary changing with deafness, congenital deafness. This is one of my patients with Bardet-Biedl. So you can see the little pigmentation compared with the typical retinitis pigmentosa that we are seeing. He has a syndactyly, and his one of the finger get amputated. And this patient, he has, with a follow-up, he developed like a Coates-like picture. You can see the peripheral exudation, and I mentioned that peripheral neovascularization exudation can complicate retinitis pigmentosa. And you can see the corresponding fluorescein angiography, the ischemia that he has, peripheral ischemia. This patient we treated with a laser and cryo. So in general, the differential diagnosis, deafness and pigmentary retinopathy, you have to put this listed form: Roughsome, adult Roughsome, Cockayne syndrome, Alstrom disease, Flynn-Aird syndrome, Friedreich ataxia, Kinshire syndrome, and BBS. So by this, we finish the diffuse photoreceptors, whether it is primary or secondary. And just this table listed if some patient presented what we call with the pseudo-retinitis pigmentosa. They are not retinitis pigmentosa, but they have these listed findings, listed causes. For example, retinal inflammation disease, especially rubella retinopathy, syphilis, toxoplasmosis, herpes infection. So sometimes you ask for the torch to be sure that this is not, you are not dealing with intrauterine infection rather than retinitis pigmentosa. Autoimmune, paraneoplastic retinopathy, especially with the choroidal melanoma. Sometimes the patient presents with retinitis pigmentosa picture. Drug toxicities, especially thioridazine and chlorpromazine, quinine, hydroxychloroquine, and chloroquine, can cause pigmentary changing. Trauma can cause pigmentary changing. To use unilateral subacute retinitis, and as I mentioned, put it in your mind, is the deficient diagnosis of unilateral retinitis pigmentosa. Group pigmentation of the retina, what we call beard track pigmentation, also can mimic the presentation of retinitis pigmentosa. So the second part, it is a macular dystrophy. So this table shows the most common macular dystrophy that we are seeing in our practice, and we will go for them briefly one by one. Let's start with the Stargardt disease. Stargardt disease is the most common juvenile macular dystrophy and a common cause of central vision loss in adults younger than 50 years. The age of presentation ranged as early as 5 years and later than 50 years, so it's really variable presentation. Loss of visual acuity, which can be as mild as 20/30 or as severe as 20/200. The early onset, the severe visual loss. Let's talk about the ABCA4 gene, which is the most common cause of Stargardt disease. The variation in ABCA4 are the most common cause of autosomal recessive retinal disease in a human in general. So always memorize ABCA4 and perforin as a cause of retinal dystrophy. The ABCA4 encode an ATP binding cassette ABC transport protein. It's expressed by rod outer segments. The function of this gene is to clearance of retinoid intermediate of the visual cycle, which is corresponding to A2E. This is a toxic material in which should be cleared up during the visual cycle. Accumulation can cause toxicity of the photoreceptors and retinal pigment epithelium. The gene is very large. It's formed by 50 exons and has many polymorphisms. More than 650 disease-causing variants have been identified. So it's really a big gene, and many diseases can caused by this gene. ABCA4 responsible for more than 95% of cases of clinical Stargardt disease, 30 to 50% of cases of rod-cone dystrophy, and 8% of autosomal recessive retinitis pigmentosa. The disease spectrum is determined by the total amount of residual ABCA4 function. The much deletion, the more phenotypic or severe presentation. For example, the mild deletion, which is corresponding to the Stargardt disease, which is we regard it as a mildest form of ABCA4 phenotype. However, retinitis pigmentosa is the most severe one because of amount of deletion of ABCA4. And the remaining 5% of cases of Stargardt disease phenotype are caused by mutation in ELUVLA4, PRPH2, and BEST1. So the most common gene causing Stargardt disease is ABCA4. Clinical feature of Stargardt disease. Variable, and it is maybe related to the severity of their ABCA4 genotype, as I mentioned, the relative sensitivity of the foveal cones to the genotype, and the relative sensitivity of the retinal pigment epithelium to the genotype. The most characteristic fundus finding is light-colored biscuiform fleck at the level of the retinal pigment epithelium, and usually they are sparing the optic disc. It can be numerous to nothing. Sometimes you are seeing genetically proven Stargardt disease with no flecks. RP atrophy in the center of the macula, which looks like a metallic sheen. Epiretinal membrane, subretinal fibrosis, inflammatory nodules, also we are seeing in our practice and according to the study. And the fluorescein geography and autofluorescein, because of the accumulation of this toxic material A2E within the retinal pigment epithelium, results in detectable abnormality on both blockage by autofluorescein and by fluorescein geography. So fluorescein geography, we refer it as dark or silent or mask choroid phenomenon, which is present in 80% of the patients. So it is not a pathognomic sign for the Stargardt disease, but it is common. The autofluorescein imaging area of RP atrophy, bullseye, changing in the macula, fleck, and peripapillary sparing. And this is really identical. The peripapillary sparing of the fleck is identical for Stargardt disease. OCT can show outer retinal loss and RP atrophy, and ERG usually normal. And this is the typical picture of Stargardt disease. As you can see, the fleck retina in the macula. As you can see, the fleck retina in the macula and also around the fundus, but mainly in the macula. And this is one of my patients. You can see the beaten bronze appearance of the macula, but you cannot identify any visible fleck. This is the pattern. You can see the loss of RPE, and you can see the fluorescein geography show dark choroid, and you can see the hyperfluorescein, which is corresponding to the window defect, and you can see the foveal atrophy and the secondary loss of outer nuclear layer in both eyes. Thank you. This is another patient with a subsequent follow-up. She is 30 years old. Vision is 20/100, and you can see like a kidney-shaped RP atrophy, and you can see the beaten bronze appearance of the macula in the other eye. This is more advanced cases in which you get severe RP atrophy and choriocapillaris, and you can identify this flecks around it. And sometimes even you have pigmentation around it. And really, with this picture, different diagnosis of the bullseye maculopathy with the pale disc. There is another entity of Stargardt-like dominant macular dystrophy. Remember, Stargardt disease is autosomal recessive, but there is also autosomal dominant variant. The mutation in the dominant gene in STGD4, ELOVA4, and PRPH2, it's characterized by progressive central vision loss, and it's characterized by biscuiform fleck, but usually they are larger and better flight distribution. Peripapillary sparing, the same in the usual Stargardts, and macular atrophy can develop macular atrophy without development of reflective sheen that we are seeing in the typical Stargardts. Fluorescein angiography, dark choroid, less frequent than the autosomal recessive Stargardts. So this is the picture of autosomal. You can see the fleck, it is somehow larger, and it looks like a butterfly distribution. And sometimes you have a massive RPE atrophy. In general, if you see this picture of bullseye that I showed you before, it is a really differential diagnosis. You cannot sometimes predict with only appearance of macular dystrophy. That means the patient has Stargardts. So one of the differential diagnoses is Stargardt disease, but also remember Cone and cone rod dystrophy, chloroquine retinal toxicity, age-related macular degeneration, chronic macular hole, central areolar choroidal dystrophy, olivopontocerebellar atrophy, and ceroid lipofuscinosis. The treatment of Stargardt's recommendation as intravitreal pigmentosa, dark glasses and had during exposure to prolonged bright light to reduce the rate of formation of all trans retinol in the photoreceptors can be helpful. Avoidance of cigarette smoking, one study showed that, but it is not proven. Avoidance of high dose of vitamin A supplements, because especially even the tablets that include the arid formula for AMD vitamins, because of their potential to increase the formation of retinoid in the retina and give you more toxicity. So we always encourage the patient to avoid the using of vitamin A, as it might exacerbate their disease. It is suggested but not proven by the study. There is ongoing study about the treatment of Stargardt's, like isoretinoid and ferroretinoid drugs that modulate the visual cycle, give you some promising result, gene replacement therapy, and RPE cell replacement. So by this, we finish Stargardt's disease, autosomal recessive and autosomal dominant. We will move now to the best macular dystrophy. It is autosomal dominant, caused by mutation in the BEST1 gene, formerly known as VMD2, which is located in the long arm of chromosome 11 and encode the protein bestrophin. The bestrophin localized to the basolateral plasma membrane of the RPE and function as transmembrane chloride channels. The resulting lipofuscin accumulation may be secondary to abnormal ion reflex. The prevalence is 1 in 10,000 individual. It's characterized by vitelline dystrophy, vitally eruptive degeneration, vitelliform dystrophy. This description because of egg yolk-like appearance. Visual function is usually preserved, if no complication. EOG iodine ratio is typically severely reduced or sometimes absent. Hyperopia and angle closure glaucoma are common finding. This is the classic form of vitelliform egg yolk-like lesion. It is single, symmetrical egg yolk-like lesion centered in the fovea. This is the larger, this larger lesion. Sometimes we are seeing this earlier in life. This patient of 6 years old. And this is also large. And this is the typical presentation by the OCT in which you have the accumulation of the lipofuscin underneath the neurosensory retina. And this is masked by the autofluorescence. It can be small as this one, this corresponding autofluorescent. It behaves as a hyperautofluorescent because of the damage of photoreceptors and underlying RP and underlying photoreceptors. And you can see this is sequestrated underneath the neurosensory retina by the OCT. Usually they have a good visual acuity. This is the typical for what we call pseudohypopia, which is layering of hypofusion. With the chronicity, you get, with the gravity, you get layering of this lipofuscin. Still, the patient maintaining a good visual acuity, unless he develop a macular scar, like this slide. Or he developed CMVM, which need a treatment. So the loss of the visual acuity can be to sub-RPE fibrosis, due to geographic atrophy, due to submacular hemorrhage, and sometimes you have this hemorrhage without CMVM formation. And this one, this patient developed classical CMVM in which need a treatment with anti-VEGF. Best disease can present with the multifocal, not on the solitary or classical one that I showed before. And this is an example of a severe form of Best disease in which in which you can see the bleb of neurosensory retina with the lipofuscin deposit, and also another bleb of neurosensory retina with lipofuscin bordering the elevation. It can present with severe choroidal atrophy at this eye, and you can see the vitelliform appearance of the lesion. Autosomal recessive bistroretinopathy is another form of BEST. Usually it is multifocal, yellowish changes in the macula and characterized by cystoid macular edema, hyperopia and abnormal EOG. Visual acuity tend to be worse than autosomal dominant BEST, and subretinal fibrosis is common than autosomal dominant BEST. I have photos for it, but I don't know where it goes. This is adult vitelliform lesion, which is a phenotype with a mutation of the peripherin gene. And you can appreciate the vitelliform lesion under the fovea with the corresponding OCT. This slide is repeated, I'm sorry. So by this we end with the Best disease. Autosomal dominant, we have autosomal recessive, we have solitary, and we have multifocal. For the treatment of the Best disease, usually there is no treatment unless they develop choroidal neovascularization, in which you need to interfere it as a choroidal neovascular membrane treatment regimen. We will move now to the pattern dystrophy. Pattern dystrophy refers to a group of inherited retinal dystrophy characterized by pigment changes at the level of the RPE. It's a broad spectrum of clinical appearance that were originally given names based on the pattern of the pigment distribution. So why we call it pattern dystrophy? Because it depends on the pattern distribution of the pigmentary changing at the level of the RPE. It can be in the butterfly shape, can be or the other one is adult onset vitelliform pattern dystrophy, peculiar foveal macular dystrophy, joint reticular dystrophy of the RPE, and fundus pulvirulentus. It is autosomal dominant inherited, and the causative gene is PH2, which is encoded a structural protein called perforin that maintain the morphology of the photoreceptor's outer segment disc, which is the primary defect. And as I mentioned, always remember perforin, 2 gene, ABCA4 and perforin, to cause the retinal disease. So mutation in this gene can present with central areolar choroid dystrophy, fundus flavimacularis variants of the Stargardt disease. And most common visual dysfunction is macular photostress, which is the central acuity will be slow to recover following exposure of the bright light. And this is a usual complaint of the patient, even with the normal ERG visual field and visual acuity. The choroidal neovascularization is a common complication in pattern dystrophy, account 18%. ERG are generally normal, except for a borderline or mildly reduced EOG consistent with the diffuse RPE. The more severe, the more diffuse RPE, you can get some abnormality in EOG and ERG, which is really quite rare. And this is the distribution. The upright is in the form of butterfly appearance. The left, it is the adult onset vitelliform, and the down is Sjogren reticular, which is the reticular pattern distribution of the pigmentation on the retinal pigment epithelium. This is the peculiar foveomacular dystrophy, which is first prescribed by GAZ, and really you cannot identify it. The patient is symptomatic, visual acuity is good, but really you cannot identify it, very subtle, which is corresponding to hypoautofluorescence run by hyperautofluorescence by fluorescein angiography. This patient, with the follow-up, he developed like a Sjogren reticular dystrophy of the RPE pattern, the same patient. Fundus flavi maculatus, which is a variant of Stargardt disease, it is also caused by perforin-caused pattern dystrophy. However, the phenotypic presentation looks like a Stargardt's, Fundus flavi maculatus. And usually they present with this flex, which is sparing the optic disc, and rarely involve the macula. However, we label it as they label it as a pattern because you see the pigment halo, this typical presentation of pattern dystrophy. So they label it as a pattern dystrophy. Central choroid dystrophy, as this listed, also which is caused by the same gene. I will speak about that in a minute later on. The other macular dystrophy is Sorbet fundus dystrophy. It is autosomal dominant inheritance. The disease is caused by mutation in TIM3 on chromosome 22, cause for tissue inhibitor of metalloproteinase, which is involved in the extracellular matrix remodeling, and is characterized by submacular hemorrhage secondary to CMVM and pigmented changing in both macula. Age of onset is 40 to 50 years. Characterized by progressive atrophy of the peripheral choroid and RPE. An early sign in the disease is the presence of numerous fine drusen-like deposits or a confluent plaque of family yellow, of faintly yellow material beneath the RPE of the posterior pole. And histological specimens show a lipid-containing deposits between the basement membrane of the RPE and inner collagenous layer of the proximal membrane. So it is really looks like the drusen that we know about it. So this is the modeling of the RPE, and really you can see the drusen. And this is secondary to subretinal hemorrhage and macular scar. And you can see the diffuse chororetinal atrophy. It is, by the way, a rare entity. Until now, I didn't see it in my clinic. This is just from the textbook. The early onset drusen, or familiar, it appears in younger ages, usually numerous and vary in size, typically extending beyond the vascular arcade and nasal to the optic disc. The inherited pattern in the vast majority of the young patient is never established. The classification: large colloid drusen, which is correspond to large, yellowish, and bilateral lesion. Malacia levantines, which we are seeing this in our practice, and cuticle drusen, which they called as a basal laminar drusen or pattern dystrophy, which is resembled to pattern dystrophy phenotype. So I'll speak about the autosomal dominant radial drusen, which is Donny honeycomb retinal dystrophy, and other name is Malacia levantinus. It is autosomal dominant mutation in the gene of EFEMP1 located in chromosome 2. This gene encodes an extracellular matrix protein known as fibulin 3. Its characteristic radial distribution of the drusen at the temporal periphery of the macular lesion, present with white clinical appearance, clinical presentation. The drusen in the center of the macula and on the nasal edge of the optic disc tend to be larger and round, while those at the temporal, it's smaller. OCT can demonstrate retinal edema, loss of foveal control, pigment epithelial detachment, and intense sub-RPE reflectivity. It's characterized by hyperautofluorescence as a drusen. Visual acuity usually preserved until central atrophy, pigment proliferation, CMVM develop later. So this is one of my patients which present with the choroidal neovascular membrane. And you can see this drusen. It tends to be larger and nasal to the disc and more superior nasal inferior than the temporal one. This is another example, and you can appreciate the drusen with the RPE atrophy and pigmentation. Sometimes really it can give you severe visual loss because of the macular atrophy and subsequent pigment proliferation. And you can identify the drusen, how it's large. Another macular dystrophy is North Carolina dystrophy. Other name is central areolar pigment epithelial dystrophy. It is autosomal dominant macular degeneration. Location of the gene is in chromosome 6. It's bilateral, symmetrical, and the most characteristic lesion is a confluent yellow spix in the central macula to a circular coloboma with a shiny concave base surrounded by white fibrotic rim. Visual acuity is different, and it is severe if it is with severe involvement of the macula. And this is the typical pictures of North Carolina. You can see the modeling of the RPE with the deposits that corresponding with the hyperautofluorescence. And you can see that it looks like a macular coloboma with a shiny fibrotic edge in the late stage, early, middle, and late. Other macular dystrophy is polycystic dystrophy. It is autosomal dominant inherited. Lesion is round, flat, pigmented spots with or without surrounding hypopigmentation, as shown in the slides. Cysts in multiple retinal layers and new vascularization can happen. Amblyopia and strabismus are frequent because of early presentation. The last macular dystrophy is the dominant cystoid macular dystrophy. It is autosomal dominant. The gene locus on short arm of chromosome 7. It's characterized by leaking perimacular capillaries, whitish punctate deposit in the vitreous. By the way, it is very rare dystrophy, and even I didn't see it in my lab. This is from the textbook. Characterized by normal ERG, subnormal EOG. Hyperopia can be associated, and in late stages can present with atrophic central beaten bronze macula. And that's why it's one of the differential diagnoses of Bull's maculopathy. Another macular dystrophy, which is, I think this is the last macular dystrophy. It's a fenestrating sheen macular dystrophy. It is also autosomal dominant, characterized by central macular sheen with small fenestration. It is typical picture for that. I took it from the textbook, and we didn't see it in the daily practice. It's variable presentation in age and visual acuity, and bullseye pattern of stippled hypopigmentation the central macula can develop. Glomerulonephritis type 2 and drusen. Sometimes drusen, you can see it with the glomerulonephritis type 2. It characterized by the presence of subretinal deposits with a clinical appearance on the basal laminar drusen. Usually they preserve a good visual acuity, unless complications occur in form of choroidal vascularization, exudative drusen, or serous detachment. And morphology and the composition of this drusen is similar to the drusen that you are seeing in the AMD. So by this, we finish the macular dystrophy. Let's go to the third one, which is the inner retinal and vitreoretinal dystrophies. The most common one is the X-linked retinoschisis. Retinoschisis refers to a splitting of neurosensory retina. Human inherited retinal degeneration, it is caused by mutation in the RS1 gene on XP22.1. RS1 gene encode an adhesion protein called retinoschine, which localizes to all retinal neurons. It affects molar cell health and causes molar cell degeneration. And you remember the molar cell extends from the external limiting membrane to internal limiting membrane, which is formed by photo process of the molar cells. So this integration of these molar cells can lead to schisis. The X-linked retinoschisis is the most common form of juvenile onset retinal degeneration in males. The prevalence range between 1 in 15,000 and 1 in 30,000. The clinical features of X-linked retinoschisis, foveal schisis, is the characteristic sign, which is present almost in 98 to 100% of the cases. Peripheral retinoschisis is often noted in the infratemporal region and is present in 50% of the cases. It characterized also by presence of vitreous veil, subretinal linear fibrosis, pigmentation, white retinal flakes, and visceral attenuation or sheathing peripheral retina. The sight-threatening complication is caused by tractional or recombinant detachment, 5 to 20%. Dense vitreous hemorrhage in third of the patient. That's why when the infant presents with a vitreous hemorrhage, also think about X-linked retinoschisis, because sometimes they present with the vitreous hemorrhage. Sometimes hemorrhage happen within the schisis itself and cause poor vision. And sometimes interretinal splitting involving the macula also can cause poor vision. Rare complication, neovascular glaucoma, vitreoretinal traction with secondary macular dragging, and optic atrophy, which looks like ROPs. ERG is a diagnostic parameter. Negative wavelength is reduced, B wave amplitude with a relatively preserved A wave amplitude, because remember the B wave is generated by neuronal cells, mainly the bipolar. And we see that cases occur in neurosensory retina with a preserve of photoreceptors. The differential diagnosis of foveas or X-linked foveas cases, retinal detachment, cystoid macular edema, whether from diabetes, inflammation, or another entity. Degenerative retinal cases, but usually degenerative cases occur in the outer plexiform layer and peripheral and older age. Acquired retinal cases, Goldman-Fabry, vitreoretinal degeneration, and S-enhanced Ehlers disease, VCAN-related vitreoretinopathy. This is a case typical of foveas cases. You can see the cartwheel appearance of the macula with corresponding cases by the OCT and hyperfluorescein by the fluorescein angiography, suggesting some few leak. This is one of the cases with juvenile retinal cases. In this patient, I follow him for 10 years. In the right eye, he developed retinal detachment, which is very bad retinal detachment, and we repair it, but it's filled almost with a PVR. He preserved the left eye, but you can identify the largest cases that he has in the macula. Typical presentation, nystagmus and poor vision. What's the time now? How much? Management, genetic counseling, pharmacological, like carbonic anhydrase inhibitors, laser photocoagulation, surgery, gene therapy, retina or progenitor cell transplantation to restore some vision. The other entity of retinal nuclear receptors of the vitreoretinal degeneration is retinal nuclear receptors, which is NR2E3 related disease. It is autosomal recessive retinal degeneration of variable severity, including S-enhanced cone dystrophy, Goldman-Fabry, and clumped pigmented retinal degeneration. This entity occupies 0.5% of retinitis pigmentosa. The NR2E3, which is retinal nuclear receptor subfamily 2, group E, member 3, formerly called photoreceptor specific nuclear receptors, PNR. Mutation in that gene may suppress cone proliferation during retinal development. And mutation in that gene lead to absolute increase in the S-cone. Remember, S-cone is responsible for the short wave. At the expense of M and L, which is medium and long wavelength responsible cones. Also can lead to decreased rod development and retinal disorganization and degeneration. The clinical finding is by the Goldman-Fabry or Fabry macrofibrillated vitreoretinal degeneration characterized by early onset nyctalopia, fibrillated vitreous degeneration, macular retinoschisis and cystoid macular edema, peripheral retinoschisis, pigmentary choroidal degeneration, intraretinal pigmentation, which is described as a spot, not as a bone specule. Cataract also common, and ERG can cause flat ERG. The S-enhanced cone dystrophy almost is the same as Goldman-Fabry without involvement of the vitreous. And this is the typical picture of the Goldman-Fabry, in which you can see the pigment spot, you can see the hyperbolic disc, you can see the foveal cases, and you can see the generalized choroidal atrophy. This is another pigment clumps. And this case with a subretinal fibrosis and foveal cases in which we manage it with the trosopt and the macula get flat. Management, genetic counseling, pharmacological treatment like carbonic anhydrase inhibitors like topical dorzolamide, which is really work very good in these cases. Laser photocoagulation surgery. Laser photocoagulation nowadays no more use as a foveal case. This is in the past. This is one case of the Goldman-Fabry syndrome, which I follow up with the cystoid macular edema and the trosopt. You see the macula how it nice get flattened. And this is all this slide in which they do macular laser for the cases, which is nowadays not used. For hereditary choroidal disease, I will postpone it to the next lecture because really there is no time. It is, as I mentioned, it's a very long subject, heavy, and I hope you grab some information. Thank you very much. I'm happy to answer any question after the lecture because really now there is no time.
فاينك هاي already طويلة تعبت. Good luck.
Thank you. How are you, Omar? What is your real name? Wilfredo. I know there is a Spanish name. This is yours. I have my own one. You have to turn the lights off. I'm ready. And I was ready. Yes.
Assalamu alaikum. Good afternoon, ladies and gentlemen. So it's my pleasure to introduce one of our active faculty in the anterior segment division, Dr. Jose Vargas. He presented to us earlier some topics under the Boston Cabro 3 months ago, and today he's going to give us the second part of the Boston Cabro, and he will focus on the expanding indications, some of the complications, and some of his experience cases that he did before. So I would like to welcome Dr. Vargas, and we'll entertain the questions at the end of the presentation. Thank you.
Thank you, Dr. Swelling, for the presentation and for the opportunity to be here. Today I will, as Dr. Samar mentioned, I will go over some of the new growing indications for keratoprosthesis, but I also will go over complications, and some of those complications you saw in my last presentation. And you might say, why will Dr. Vargas give again some of these complications? The answer is because those are the most common complications that we will face when we use keratoprosthesis, and I really don't want to lose an eye, either my fault or the fellows or the resident or another consultant fault for not recognizing the complication or for not knowing how to treat it. Sometimes you cannot recognize it, and with keratoprosthesis, we really don't have much time when we have a complication. As I say, it's an honor for me to be here. I have no financial interest to disclose in this presentation. I want to acknowledge some of the people that helped me to do this presentation, as Jamal, Robert Jones, Winifredo Prado. It's better, Winifredo, if we call you Omar, easier than Winifredo. This is a Spanish name. Sami Algadi and Mesher Algadi. We all know that all the corneal procedures, either PKP, lamellar keratoplasty, or endothelial transplants, are affected the need for the treatment of and the management of the majority of cause of corneal opacification. So if we know that, why would you attempt to develop an artificial cornea if we know that standard surgery for the corneas are giving us really good results? If we check at the data that we have right now, we will know that we have like between 10 to 12 million people suffering for corneal blindness around the world. Out of this, 1.5 are kids. And of these kids, most of them are heavily vascularized, which is an additional problem. And we know that worldwide, we only do 100,000 cases of cornea transplants, and this is probably 1% of what we need. We need to do 100%, which means 10 millions. If we do 1% of this, which is 100,000 per year, it will take 100 years for us to finish that 10 million people. It's a long time. It is important to know that the great majority of these corneal problems are in the developing countries. And in these developing countries, the large prevalence are in poor people, very low-income developing countries. We all know that corneal transplants, after hearing this, they're not going to solve the problem. Besides that we're only provided 1% per year, donor tissue lag well behind needed. There are a lot of cultural, religious, and economic factors. Corneal vascularization is another problem that we see in many cases. And as far as I know, we don't have any medication that can make 100% regression of the vascularization. Oh, that's a problem there. And we also know that repeat corneal transplant is not successful in the long term. We all know that not all blind conditions are amenable to corneal allograft, lamellar or otherwise. I'm very sure that everybody in this room have patients like this who have had repeat corneal graft rejections. And we know that after every corneal graft rejection, rise the risk for subsequent graft rejection. This is a very important data from the Australian Corneal Graft Register. They said that only 55% of corneal transplants are still clear after 15 years after the surgery. And this is a very short period of time. The number gets worse if we get the keratoconus patients out of these numbers. If you see this graphic here, it is a very impressive data, but not the most fully representative, but it's very impressive. It's a paper from Verdowski, and it was published in 2001 in Ophthalmology. And this study shows that the third graft, or the third regraft, has a survival in 5 years of essentially 0. And those are very bad news. Corneal scarring opacifications are a very common cause of blindness. We all have cases like this that we know that if we do a corneal transplant, the corneal transplant will fail. So we have to really think about Boston keratoprosthesis as an alternative for either patients with multi-graft failure or patients with severe ocular surface disease. The indications I already mentioned in my last presentation. What is more important is the contraindications. We really have to be careful when we do keratoprosthesis in patients with severe dryness, ocular surface keratinization, severe eyelid dysfunction, and end-stage glaucoma. This is the keratoprosthesis we had at the beginning, back plate with 8 holes. And now it was modified and jumped up to 16 holes. The material we have, or the type, we have 2 types, type 1 or type 2. Type 2, I don't use it. I think that I only did 1 case with a very bad results many, many years ago, and only use a type 1. Type 2 is reserved for very severe ocular surface cases. We have only 2 models with a backplate modification. We have the clip-on, which is only titanium and measured 8.5 millimeters. And we have the snap-on, which is the one that we used until a few years ago, and still have it, but most of the cases you can request a clip-on. And this one comes in 2 materials, PMMA, and comes in titanium. And comes in 2 sizes, 7 millimeters and 8.5 millimeters for adults, 7 millimeters for kids. This is a comparison between PMM and titanium. And most of the main difference will be that with a PMMA plate, we will be able to visualize if we have a RPM. With the titanium plate, we're not going to be able to do that. And either using an ACOCT, we're not going to be able to detect that there is a RPM until it reaches to the optic of the keratoprosthesis. Some people complain about cosmesis, and really it's a big difference between PMMA backplate and the titanium one. The company decided to change and improve the quality and the better cosmetic for these patients. So if you want to select the patient for titanium backplate, it's important that you can request either for blue, green, and amber colors. These are very similar, but it doesn't work very well with dark eyes. Of course, we have complications, and as I mentioned before, I'm going to go over some of the complications that we had before, or that I showed before, because those are the most common ones, and they're very, very important to recognize at the right moment. That was in 1995. By that time, only 15 keratoprostheses were implanted in the United States. Boston K-Pro was approved in 1992, and imagine from 1992 until 1995, only 15 were implanted. The reason for that is because there were a lot of complications with this. Now, we have a better long-term results because now we use fresh cornea tissue. We have gone from 8 holes to 16 holes, and now we use as a routine. We put a contact lens in these eyes. Long-term is a topical antibiotic, which is very, very important. And we have the possibility of new glaucoma treatment. But can we only use fresh tissue to obtain really good results? The answer for that is no. There is going on people using gamma irradiated corneas and also frozen corneas. And if the results between the frozen irradiated corneas compared to the fresh carrier tissue are the same in terms of complications and in terms of good outcome. So it doesn't matter if you use fresh, it doesn't matter if you use gamma irradiated, it doesn't matter if you use frozen one, the results are going to be the same. The advantage of having the irradiated ones is that you can supply this to anywhere in the world without having the time behind your back. As the fresh one, you have a time to be delivery. And there are places in the world where you cannot deliver because of the time. With the irradiated ones, you can do it. So this is a paper just to show which are the principal indication or the main indication. Not only this paper, all the papers show that the principal reason for doing a keratoprosthesis in the United States and other centers all around the world are the graft failure. And the complications are the same. The most common complication is the RPM, followed by high intraocular pressure and glaucoma. There's a lot of data that shows the good result with the Boston keratoprosthesis. This is a thought by Dr. Manis, who says that the postoperative care of this patient is complex and is associated with a significant complication. This is the most important one. As I mentioned before, and I want to mention this again, one of the problems that we have here is that we have a very long waiting list for our patients, even post-op or regular follow-ups. When they come here, it could be 1 month, it could be 2 months, but it will probably will take a long time for them to arrive here. If you do a graft, a normal graft, and it fails, patient might come here complaining of poor vision because it fails. But if you have a keratoprosthesis and the patient gets lost, the patient might return with a keratoprosthesis in his hand. Because the complications that we have with Boston keratoprosthesis are very severe if you compare with regular keratoplasty. This is the most common complication, which is the RPM. As I mentioned, it's a fibrous membrane that originate from active host stromal cells that migrate through the gap in the graft junction. It is the most common. You can find in different literature, and it goes from 25% to 65% of the patients. They are clinically significant, and they can produce an occlusion of the visual axis, and they can increase, actually they increase the risk of keratolysis. There are two there are two things that you have to keep in mind. If you have a patient with a clinical history of infection keratitis or aniridia as the reason to go for a Boston keratoprosthesis, and you have a corneal melting, or you have a problem with you see the membrane, you have to think about RPM, because these two comorbidity are the ones that increase the possibility of having RPM. How do we evaluate those? We can clinically with a slim lamp. When they go over the optic, or you can use the anterior semming OCT. And the anterior semming OCT will allow you to find out what it is, especially with the PMMA plates. With the titanium plates, you're not going to be able to see it until it reaches to the optic. Sometimes if there is very, very thick, you're going to be able to see it in the OCT. This is just to show some studies done by Jose de la Cruz and Illinois, and you can see that you can find from different thickness, going from 278, and at this level they know that you have a patient with an RPM. With this RPM is 278 or more, you will have a high chance for melting. And under 193, there is no possibility of melting, or there is a decreased chance for melting. This is just to show where the possibility of the different places where these membranes can come from. And there's a study that suggests that it's a possible epithelial downgrowth that has been evident in a very high number of patients. If this is an inflammatory membrane, in few cases you will see a histopathological analysis where it shows a few inflammatory cells, but most of the cases doesn't show any inflammation. Does it come from the donor or does it come from the host? There is evidence that in some cases it can come from the donor, or it's a combination of donor and host. When I saw the first report from the Harvard Foundation, I was really excited about seeing the titanium backplate coming into the market, because the histocompatibility of this titanium was very close to be the real factor to avoid RPM. And we had that on mind for a long, long time. And we say, well, life for the PMMA backplates is over. Unfortunately, that's not true. And there is a paper that just came a few months ago from this group from Jose de la Cruz and Maria Soledad Cortina. And they analyzed a group of patients who developed RPM. And at the end, they compare and they say that there is no difference in the RPM formation between PMMA and the patients with titanium plate. How do we prevent the RPM? In my previous presentation, I had the titanium, I have the titanium here. But now I erase it because according to this study and according to different other experience, there is no difference between using PMMA and titanium. So I erased that one. And now we know that the best way to prevent the RPM is a better wound apposition. There's a group in Miami at the Bascom Palmer that are working with larger backplates. Instead of using 8.5, they're using 9.5 millimeters, and that will produce a better apposition of the graft and the host and decrease the possibility of RPM. As I said, there is very little inflammation in the histological study, so we assume that using steroids it won't make that much difference in these cases. The treatment is JAK laser, pars plana membranectomy, sometimes, as we saw in my last presentation, K-pro removal or exchange. This is Dr. Osorio's case that I presented in last presentation. I present the surgery. As you can see, there is almost a total melt, but you don't see any aqueous coming out of the eye. And this is because the RPM is covering the total surface of the backplate. This is the post-op result, excellent surgery and excellent result. I mentioned also that I don't have, or I didn't have in my cases, I did 110 cases, a regular follow-up 75. I have 2 cases where I have an RPM. No, it's a regular follow-up. They got lost and didn't return to the clinic. 2 of these cases were kids. I didn't have any adults that I have done that I have an RPM, or maybe that I was not aware that I had an RPM. And I did vitrectomy. The only common factor in all my cases, I did either pars plana vitrectomy or anterior vitrectomy. In 100% of those cases, 75 cases with a regular follow-up, I did vitrectomy on them. And the reason why I did the vitrectomy is because I was trying to avoid the vitreous to come and occlude the tube for the glaucoma, because I knew that sooner or later I was going to need to use the glaucoma shunt. By that time, I was not aware, or not everybody was aware, that if we used the shunt before, we had a better prognosis. So that was the reason why I did the pars plana vitrectomy or the anterior vitrectomy in those cases. This is a video just to show the anterior vitrectomy. There's nothing to see here. This paper came out in ophthalmology in 2017, this year. And the purpose of the study was to determine the impact of total pars plana vitrectomy with peripheral shaving of the vitreous base on the rates of postoperative complications in patients with aphakic snap pump type 1 Boston keratoprosthesis. This is the first model with a locking rim. And the conclusion for this is that those cases that had a complete pars plana vitrectomy did much better than those cases that had a partial pars plana vitrectomy or an anterior vitrectomy. The incidence of RPM that needed surgery was very, very low compared with the other cases. So I assume that what I did, know what I did because of the RPM. Now at this moment, 9 years after I started doing this surgery, shows that it is a benefit from the patient to do a pars plana vitrectomy. Not only for the RPM, there are other complications that are less, like melting and retinal problems that are less when you do the vitrectomy in those patients. Glaucoma is another complication that we have to be aware and that we have to really care about this, because sometimes the patient can be coming to your clinic, you can touch the eye, because this is one of the ways to measure the intraocular pressure, and you feel that the eye is soft, but then at the end, you will see that some of these patients we have ended with a very bad visual acuity. And you might say, well, the patient was with IOP, was controlled. Why do we have this, and why we have an optic nerve like this? Nobody knows the reason, unless you have a very evident high intraocular pressure or uncontrolled intraocular pressure. But how can a patient with a normal or low intraocular pressure can develop optic nerve damage and end with a very bad outcome? I already mentioned the mechanism of the glaucoma. There is an idea that there is a progressive angle closer in these patients. Also, the routine use of steroids is another reason. And because we replace part of the cornea, and there is a less surface for absorption of the medication. This is just to show, and in a progress of 1 year, we have an upper angle, okay? And this is 3 months post-op, 6 months, and 12 months. There's a total angle closer in this patient. This is another OCT to show the same. But we still have to keep in mind that the AC-OCT is an important tool to evaluate the angle. It will show you if there is a closer angle, if there is a modification of the angle, and if there are synechnias. This paper was published in Cornea in 2017, and we have, until that moment, the idea that all the patients had glaucoma because the angle will be closed with the time. This paper showed that they evaluated a good population of patients, and they visualized the angle anatomy of 66.1% of these eyes, including the backplate study. Neither the material nor the size of the posterior backplate had a significant impact on the angle anatomy, which means that the fact that we're having the keratoprosthesis is not the main reason why we will have the angle closer. Otherwise, we will have an angle closer in 100% of the cases. And this is a very important study with a very large number of cases. How do we diagnose the glaucoma? We have to, if we can, sometimes we cannot do, we have to do visual field, we have to do optic nerve OCT, and we have to use your fingers to see if the intraocular pressure is fine. Until now, we think that the only way to have an accurate measurement of this is with the finger. But there's this paper that came out in Cornea in 2015 that says that you can use the Schiott tonometer either at the limbus or in the temporal sclera, and it's a very accurate, or it's more accurate than the tonopen and the other gold standard digital anemometry. And this is important. I have never tried to measure the intraocular pressure, but it will be good to try and see it gives you an accurate result. This is a very interesting paper where they evaluate 106 cases that underwent Boston keratoprosthesis. 65% of these cases, they have glaucoma before the surgery. And 26% of these cases, they develop the glaucoma after the surgery. What is important about this study, it doesn't matter what was the indication to do the keratoprosthesis. The final message for this paper is that all the patients end bad. It doesn't matter if you control the IOP, it doesn't matter what you do, all these patients will end bad. And that's a very sad ending. And this is a very sad paper that I really would like to take it out because of this, but this is the reality. So what should we do with these patients? Patients with glaucoma or patients without glaucoma that are going to get into the surgery, they should have the surgery before or at the time of the keratoprosthesis. If you have a patient that even with the surgery has normal intraocular pressure, Boston recommends you to use prophylactic anti-glaucoma medication in this patient, even if the eyes are soft. And the reason for that is they believe that the lower the intraocular pressure is, the better the result we will have with these patients. This is a paper that was published in 2017 that agree with this. We have to do the surgery, the glaucoma surgery, either before or at the time. If we do it after the keratoprosthesis evaluation, keratoprosthesis implantation, the results are not going to be good in these patients. This is for the valve. The indication, or not only the indication, the placement, it is better to place through pars plana. If you're going to put the tube in the anterior chamber in front of the iris, you better do at least 3.5 millimeters to avoid the contact lens, because sometimes the contact lens will rub the surface of the conjunctiva and will erode the conjunctiva. This is a guideline that is applied by Harvard, and we should really try to get this guideline here. This is the frequency of how often do we need to see these patients, only for glaucoma evaluation. As a matter of fact, we need to work. This is like a married couple between glaucoma, retina, and S, okay? Because the patients that we do corneal surgery, most of these patients will end with the glaucoma people. And some of the cases done by the glaucoma people will end with the cornea people. So we better really have a good relationship with the glaucoma because they have to evaluate this patient very, very often. But is there anything else that's been done with these patients? We know that we lost, or we will eventually lose the ocular nerve. And this is, as I see, there is not much that we can do to prevent this, even doing the surgery or even doing the prophylactic anti-glaucoma medication. Some of these cases end in very bad condition. But there is a group of people that is, I'm talking about a group of glaucoma guys that are working in a neuroprotection and in regeneration of the ocular nerve. And this is a very amazing. And believe it or not, there is a lot of work that's been done in a laboratory and beginning the transition to clinic regarding neuroprotection in glaucoma and other optic neuropathies and even regenerative therapy. And this is very, very amazing. Now they are in the phase 2 trial for CNTF in glaucoma. It's a single center, and it's investigator-initiated non-masked trial. Neurotech NT501 implant. And they are in the clinical trials right now. This is a ciliary neurotrophic factor, which is called by the CNTF, that have demonstrated in a lot of studies that enhance the survival and regeneration of the retinal ganglion cells. This is very important because we know that this is very bad affected during glaucoma. They think that the CNTF delivered into the human eyes will provide neuroprotection that will be preventing of the loss of the vision, and neuroenhancement, which will improve the vision of this patient in glaucoma. The patient in the trial will receive the implant, and this implant is made by Neurotech into the eye. It will be followed carefully to evaluate the safety and efficacy of this implant. This is the implant here. This is the capsule, which is a special capsule that in a period of 6 to 1 year, it will deliver the CNTF into the eye, and it will enhance and it will regenerate the optic nerve. This is some of the studies. As you can see, it's a big difference between the eye that it was implanted with the CNTF and the control eye in terms of activity. This is the capsule. It's a very permeable capsule that they will release the medication into the vitreous. Once again, we have to be aware of the complication that we can have. And I still see patients that comes into the clinic that they are using moxifloxacin or gatifloxacin 4 times a day. We cannot use the antibiotic treatment on these patients on a regular basis. There has to be a low dose of antibiotic, and there's a difference between how you use it in monocular patients or immunosuppressive patients compared to non-monocular patients. Also, as I mentioned, for the glaucoma, we should take this. This is the updated from Harvard, and this is what we should use here. We're trying through Dr. Samar to get the polytrin. I hope we can make it. And there was a discussion about the chloramphenicol, and I hope that we can get it here. So we can treat the patients in the way that it is. And all this way to treat the patients is based on the experience in different centers that are working with the Boston keratoprosthesis. As I said, there is a difference between treating the autoimmune or monocular with no monocular patient. The difference is the order you use the antibiotic and the frequency you use it. Soft contact lens is very important. Even if you don't think that the patient needs a contact lens, almost all the patients need a contact lens. There are less complications when you use it. You can use it for a long, long time. Sometimes you hear the patient coming to you and say, "Doctor, I need you to change the contact lens." And you check the file, and the contact lens was placed 1 month ago. And you say, "Well, I don't need to change the contact lens. It's only 1 month." The patient will say, "Yes, you have to change. The previous doctor changed it to me. The previous one changed it to me in 1 month." I said, "No. You can have, especially the contour. The contour is a lens that is designed for Boston keratoprosthesis patient because it comes in different sizes, 16, 18, 20, and 22 millimeters. And this lens can be in the eye up to for a year. When do you decide to change these lenses? If you see proteins in the lens, or if you see that the lens is not clear anymore, you have to remove the lens. But if you see that the lens, every time that the patient comes to you, and you see that the lens is clear and no proteins, leave the lens. You don't need to remove the lens. This paper was published in British Journal of Ophthalmology in 2016, and it shows you how important it is to have this contact lens. They conclude that the complications in this group of people is less if they use the contact lens compared to the group of people that didn't use the contact lens. How do we prevent the proteins to come into and adhere to these lenses? This paper was published in 2015, and it showed that if you use acetylcysteine in these patients, you will have a reduction of the possibility of the proteins into the lens, and it keeps the clarity of the lens. So this is probably, I never tried this before, but it probably will be a good idea to try and see if we decrease the possibility of proteins into the lens. I mentioned in my previous presentation my experience doing video endoscopy on the patients before doing the surgery. And we did a study, 5 cases done in Basque compartment, 5 cases done in my clinic in Venezuela. And out of the 10 cases that we had the idea, based on B-scan, that there were cases for K-Pro, only 3 cases were for K-Pro. The rest of the cases that were okay based on the result of the B-scan were not okay for surgery, okay? We have done, I think, maybe Dr. Semide will correct me with this, I think that we have done like 5 or 6 cases here where we didn't know if the cases were going to be good candidates for the surgery. And as I mentioned before, the Boston keratoprosthesis costs $3,000. Think about using in patients that we know that we're going to get a benefit. It's going to be bad to lose $3,000 in a patient that we don't know is this going to improve or a patient that won't improve. This is the first reason. The second reason, doing a Boston keratoprosthesis, as I mentioned before, we can be in front of many complications. So make sure that whatever we're going to do is going to be in the benefit of the patient, and the patient will benefit and get good vision with the surgery. If we are not sure about that, send the patient for retina. Retina will be more than happy to do the video endoscopy, and we will see if the patient will have good results or not. These are some of my cases that I did. This is the original diagnosis. I have not much difference between my data and the international data. I did 110 cases with a regular follow-up of 75 cases. The main reason for the surgery was the multi-graft failure, 37%, corneal neovascularization, 21%, chemical burn, 28%, sorry, 24% for chemical burns. I have 3 cases, 4% each one of Steven Johnson and OCP. I have 1 case each of aniridia and sclerocornea. Boston K-Pro type 1 was used in all these 75 cases. One of the cases that I did, it was in the group that I didn't return, but the results were not good just at the beginning of the follow-up. This is what I did in all these cases. 26 cases with a keratoprosthesis, plus cataract surgery, plus vitrectomy, plus ECP. You have to remember that these cases, the patient is fake. You have to remove the lens. I removed the lenses, all my pseudo-phakic patients, because all my cases were calculated for aphakia. 18 cases where I did keratoprosthesis, plus cataract, plus vitrectomy, plus glaucoma drying device. 17 cases with keratoprosthesis, plus cataract, plus vitrectomy. 8 cases with keratoprosthesis, plus vitrectomy. And 4 cases with keratoprosthesis, plus cataract, plus part-plans vitrectomy, plus silicone oil. These were patients that had retinal detachment. Pseudo-phakic K-Pro with artificial iris mouse valve, 1 case. And pseudo-phakic keratoprosthesis in 1 case. 110, follow-up for 75. No big difference between males or females. The average follow-up is 56 months, range from 90 months to 108 months. The pre-op VA range from 2400 to light perception. And this is the last data that I received from the clinic. Median best corrected VA is 2100, range from 2025 to no light perception. We have many patients with no light perception, and many patients that had a very good visual acuity at the beginning of the follow-up, and then with time the vision have decreased. Most of the cases due to glaucoma. The complications that I have had. The difference between my data and the international data is in the RPM. My first complication, 11 cases, is the progression of glaucoma. 9 cases with increased intraocular pressure, corneal melt in 8 cases, microbial keratitis, 5 cases, choroidal detachment, 4 cases, extrusion, 4 cases, retinal detachment, 4 cases, valve encapsulated blades, 3 cases, superior capsule opacification, 1 case, endophthalmitis, 1 case, and subretinal fibrosis, 1 case. This is a very sad case. This guy had 20/20 vision. He was a very young guy, was like 20 years or something, and he developed a fibrosis, subretinal fibrosis, and the vision went from 20/20 to 2200. If we think that Boston keratoprosthesis is only for patients that have a multiple graft failure or very well-known ocular surface disease, there are expanding indications now for keratoprosthesis. Remember that we consider the keratoprosthesis only as a last resource for challenging cases. Now, if you look around the world, you will see there are more and more indications, not only for cases that you didn't even think that would work, but only for cases that you can use as a primary surgery instead of waiting for different surgeries. And then this is the last one, I will use a keratoprosthesis. Now there is more and more people doing the keratoprosthesis as the first surgery. This is an indication, Boston keratoprosthesis for herpetic keratitis. We all know that the PKP in this case has a very bad prognosis. This is a study that have a total of 17 patients. 14 of these patients with multiple graft failure. 12 with history of either zoster or herpes simplex. Capro surgery in all of them. 50 out of 15, 11 of these patients, they keep their V8 at the end of the study. And no complications were observed in 10 out of 14 of these cases. And it's not a short period of evaluation. The range was from 7 months to 39 months. I guarantee you that it's very difficult for a regular PKP to be free of complication if you have a herpes in these cases. This is another study that was published in 2017 in the British Journal of Ophthalmology regarding the use of keratoprosthesis in patients with herpes simplex, virus keratitis. Their numbers are not so good, and they advise to be careful when you consider the use of Boston keratoprosthesis in patients with herpes zoster, herpes simplex keratitis. A long time ago, we had a patient here with a very severe hypotony and with a pretesis bulbi. I mentioned by that time that I had done 2 cases where I did vitrectomy and I did keratoprosthesis and silicone oil in the eye. And the patient is still doing very, very good. Please do not forget that we can use this device in patients where we think that there is nothing to do. I have seen many patients here that comes to you with a pretesis, with a failed graft, or a very vascularized cornea. Don't forget that we can offer them an alternative using a keratoprosthesis. And this is the paper that was published in Cornea in 2011, and shows the benefits of doing a combined surgery with keratoprosthesis, pars plana vitrectomy, and silicone oil in these patients. Those are hard cases. All the cases that we see with some immunological problems are very difficult cases because those are the worst. The cases that will come with more complications are the cases either Steven Johnson or pemphigo. As I said, they have the least favorable prognosis because they have a lot of melt. They are very susceptible for microbial keratitis. And there is not only melt in the graft, in the outside of the graft, there is also melt in the part of the cornea that is in the center of the stem. And sometimes, I don't know if I have that picture here, you will see the leaking coming from that part, not coming from the peripheral of the graft, coming from that part. And those are the most difficult cases to treat. This is the situation for autoimmune disease. The corneal melting in these cases is possible to be done or be related to inflammatory response. PMMA backplace has been suggested to be the reason for, or as a trigger for this activation of inflammation and subsequent necrosis in these cases. There is evidence that there is increased activity of microbial activity, and proliferation might also be a factor to the inflammation and corneal melt. And there is no data at this moment that will say that either to use titanium backplate will reduce the possibility of this melt. Should we use this keratoprosthesis in patients with children? We do have many kids that sometimes we say, well, there's nothing to do with these kids. Sometimes with a very severe sclerocornea or Peters anomaly, or they are very vascularized and there's no other option. And sometimes we are afraid of doing a Boston keratoprosthesis on this patient. There's a lot of experience all around the world. Some groups will say, yes, do it, even if you will face complication. Some other groups will say, don't even think about doing Boston keratoprosthesis in kids. The advantage of doing this, if some of these cases, if you don't do anything, these cases will become amblyopic right away. So it is better to try to do the Boston K-Pro if you decide to do it, because sooner or later that patient will improve his vision and won't be an amblyopic patient, even if we know that we might have complications in the future. The rate of the possibility of having RPM is higher in this group of patients. As I mentioned before, the Boston K-Pro allows more rapid visual recovery compared to a standard PKP, and this can facilitate the amblyopic management of these children, in whom prolonged visual deprivation can be very harmful to the normal development of the vision. And this is a paper from 2010 with these results. And as I mentioned, there is a higher risk for RPM in these cases. This is the other papers that say that the Boston keratoprosthesis is associated with a higher rate of complications, higher chance for device failure, and worse visual outcome than when you compare these kids, when you compare with the result that you get with adults. And this group of investigators do not recommend to use the Boston keratoprosthesis in the pediatric population. Aniridia is another disease where we can use with very good results. Remember that almost all the patients with aniridia will have a limb stem cell deficiency, and one of the indications for the Boston K-Pro now is the limb stem cell deficiency. This is a case that I did here at the hospital maybe 1 month ago. This is 2010. These pictures are on the tracker. This is a picture of the eye, right eye in 2010. As you can see, my first picture, I show that no cases will be done when you have severe dryness or when you have severe keratinization of the conjunctiva, of the ocular surface. As you can see here, I don't see any tears, and it is very, you see there is a lot of keratinization of the ocular surface. And this is the left eye of the patient. Both of the eyes were home motion. This patient had been blind for 31 years. This is the right eye in 2014. I saw this patient in 2016 and started treating the patient with cyclosporin 1%, Lotemax, and tears. From hand motion, the patient came to 200, and you should see the face of this patient. He was a very happy patient because of that. And you can see the big difference in the ocular surface only with the treatment that I apply on this patient. Then I sent the patient to Silvana to do the reconstruction of the ocular surface with oral mucosa. The reason why I did that is because if you see the previous picture, there is no way that I can put a contact lens in this patient. And we really need to reconstruct the forehead of this patient for this. Otherwise, we're not going to be able to place a contact lens. And this patient really needs a contact lens in the post-op. So she did the surgery, excellent results. As you can see, it looks moisturized, not because of the oral mucose, because the oral mucose is not going to keep the ocular surface like that. It's because of the treatment. But as you can see, now we can work and put a contact lens in this patient after the surgery. This is the surgery. It was done, I think, a month ago. Okay. All the cases that we will face, it was a combined case with glaucoma. We did a CPC in this case. We didn't think about doing a valve because the conjunctiva was no conjunctiva. So there's no necessity of damage what we had. So we talked with the people from glaucoma, with our friends, and they joined us for the surgery, and they did a CPC. These cases I prefer to, I don't know what is behind the iris. I know that it's going to be bleeding a lot. I don't know if when I do in the trephination, I will go all the way down. I will go to the iris. And so I prefer to do trephination with a manual trephyne. These cases I did the trephyne. I'm going to do the capsulotomy. I'm going to take the nucleus out with hydrodissection. With an open sky like this, I don't like to do any maneuver to make pressure over the eye. And even having not a very friendly pupil, I was able to get the nucleus out of the back very easily. Try to remove as much as you can, and then you suture the keratoprosthesis in the regular way as you were doing a regular corneal transplant. I always try to protect and place. This is the device that comes with the keratoprosthesis. This is 3 days post-op. You can see there is a total epithelial defect in this case. And this is 6 days post-op. The patient was 20/80. Coming from 200, 30 years without seeing anything. Now the patient is 20/80. Day 12, I realized that I had a posterior synechia here. Because as you remember from the surgery, I didn't remove the posterior capsule because I didn't do a vitrectomy. And because I know that I'm not going to be able to put a valve in this patient. And so I decided to leave it like that and do a regular without removing the posterior capsule. So I see a posterior synechia here and a little bit of posterior capsular opacification here. We decided to take the patient and do a ACOCT. And I was surprised to see this here. This is with the KKESH machine that we have. Now we're lucky that our friends from glaucoma, they decide to give the machine to anterior segment. Thank you for that little present. And with this machine, you can see, there's a lot of information that you can get with this machine. You can see the optic of the keratoprosthesis. You can see the donor tissue here. And it is very important to evaluate the patient all the time and look for gaps. Gaps will be in a space between here and the body of the keratoprosthesis and here. If you see a gap, you will have more chance for endophthalmitis, and you will have more chance for melting. So this patient, everything was good here, but we saw this here. Here what you see is the titanium rim. This is the body of the keratoprosthesis. This is anterior optic, and this is the contact lens. This is just, there is no one scale for this. Some of the structures of the eye could be seen in different ways or better with any of these 3 different modalities for the KKESH. And what I'm going to show you now is a video from a 3D imaging coming from this machine. As you can see here, this is the posterior capsule, a total opacification here. This is the rim here. You will see that there is light coming through the nutrition holes. But is this posterior capsule opacification or is it RPM? It's too short to be an RPM. So I say, oh, this is not an RPM. This has to be PCO. Here you got a better view. The rim. And this is the end of the stem. And right behind the stems, you will see the opacified capsule. But you will say, why is this round? Nothing here and round here. Remember that the PMMA will allow you to go through here, and you might see all the posterior capsule. With the titanium ring, you're not going to be able to do that. You only see the light coming through here, and you will only see the capsule behind or through the optic. This is day 18. I was surprised when I saw the patient that morning. This is what is very important to follow the patient. With this severe infiltrate and a lot of discharge. At the beginning, the patient was receiving moxifloxacin, but he said that moxifloxacin was producing a lot of pain. So I decided to change from moxifloxacin, and I went to Oflox 4 times a day. A few days after that, I found this, and I decided to change the medication, and I went to vancomycin, 25 milligrams every 1 hour, and gatifloxacin every 1 hour. This is a couple days after the change of the treatment, and you see a total improvement and no more infiltrate. But, you know, all the problems comes with a lot of problems. You get the solution for one, and you have another problem. I saw a lot of loose sutures. This is something that you can see in patients with ocular surface disease, with a lot of inflammation. You will have a very asymmetric healing. And when you have an asymmetric healing, you will have loose sutures. But this was more than a loose suture. This was patient was leaking. So I decided to get the patient to the OR and resolve this little problem. I realized, and from previous picture, I know that I have an epithelial defect in that area. So I decided, okay, I'm not going to only to fix the leak, I will cover the cornea with a amniotic membrane to try to improve his healing. I finished with the sutures, and now I'm going to place the amniotic membrane. I cut the amniotic membrane with a shape that will be probably the shape of the area that is no-heal area. I use T-cell. You have to dry. The area has to be free of epithelium, and you have to be very dry. And then I place the first amniotic membrane layer there. You have a couple minutes to do that. Otherwise, it will be, fibrin will be there, and it will be very difficult for you to manipulate the amniotic membrane. Then I go for the second layer. I do the same. I dry. Only 1 drop of the blue and only 1 drop of the other one will be enough. Place the second one. When I use 2 or more than 2, I like to secure the last one. I like to secure it with sutures, even if I use the T-cell. If I use the T-cell with 1 and I really remove the epithelium, you can bet that that amniotic membrane is not going to move. 2 or 3, it will move. So that's what I decide to place some interrupted sutures to secure this amniotic membrane. And then a contact lens is placed. So this is the next day. You see a very nice position of the amniotic membrane. And once again, we have the posterior capsule here, opacification. So I decided to get the patient. He was down for the picture, so I decided to, of course, after filling the trachea and everything, asking permission and everything, I decided to do the jack laser capsulotomy. Incomplete one, because I couldn't go close to this area. This is the temporal area where you saw that there was a posterior synechia, and I really got a little bit close, and the patient started bleeding. So I decided to be away from that area. This is a magnification. You see all this area here is posterior capsule. There's the capsulotomy, and this is iris. And this, you can see here a little bit of blood. This is the OCT, the CAS imaging. You can see, now you can see the difference between the anterior imaging and this one. You can see the hole that it was done with a jet laser capsulotomy. Here, a better view. Complete PCO and the hole in the back of the posterior capsule. View from this area to the front, you can see the hole here. You can see the posterior capsulotomy and a better view of the posterior capsulotomy and the titanium rim. Better view. I still have 4 minutes. the capsulotomy here. This is a picture of the fundus of this patient. As you can see, we have a very nice ocular nerve, a very nice retina. That's what this patient is 20/80, and I assume that in the future the patient will improve. We haven't sent the patient for refraction, but I am very sure that he will improve more than 20/80. This is something that we can do here. This is a paper that was published in 2016 of the importance of doing the optos in these patients. It will show you if there is any retinal problem. It will show you the states of the ocular nerve. So I recommend to use this in any case we have. Of course, this is an immunological problem, the Steven Johnson, so we assume that we will have complications. The rate of retention failure in this case is 4.5 times higher than in other indications. How do we improve the outcomes of these patients? We need to be proactive either during the surgery or after the surgery. I'm looking for patients that I can do a combined surgery where I do Boston keratoprosthesis with a Gunderson flap. I have done partially, but not totally, so the results seems to be good for the people that is working in this. Don't forget the tarsography on this patient could be a lot of benefits, either temporal or nasal, or a tarsography like this. Even if it doesn't look very well, the patient will do well and will have less chance for corneal problems. This is the patient that I presented before. And this is to show that there is no... here you will see this is a clip-on titanium plate. You're not going to see the rim. And this patient didn't have capsule. I was reviewing the video, and there is some kind of a specification or pacification in the anterior vitreous of this patient, and this is the one. But this patient doesn't have a capsule, and everything looks normal. The advantage of this, if you can change the contrast in the machine, and you can see if there is any membrane or not. So this is a very interesting machine, and we're just getting to know how do we use it. But I think that in the future we will get to do many, many things with this. After seeing all this, you see those cases, you might think, okay, everybody has to go home. There is nothing to do with this case. I think that with the Boston keratoprosthesis, with a little bit of whatever we have available, neurimembrane, oral mucose, glaucoma, surgery, I think that these eyes, even if there is no hope for these cases, I strongly believe that every eye deserves a second chance or a fair chance. Thank you very much.
Thank you, Dr. Vargas. So I'll start just from the last slide. I agree with you. We need to probably change the indication and to broaden the indication of Kebro and to include some of the cases that you mentioned. Especially nowadays, it's the trend worldwide just to reduce the number of repeated BKs, as you mentioned, and to move on toward doing a DSEC as a second procedure for failed BKB, or to do even Kebro. And in some areas, as you mentioned, they are doing Kebro as a first-line treatment. So the indication that you've mentioned, really expanding the number of cases that we are going to do, inshallah, in the future. However, I have just one concern. As you mentioned, it's a multidisciplinary, procedure. So do you think that it can be done in every area? It's still limited worldwide, and there are some centers that are specialized in doing it, and like a referral center. So it's easy. Anybody can do Kebro, like anybody can do BKB. But the take-home message is that is everybody aware how to treat the complications or to follow the patient? That's number one. The second thing, the glaucoma, and we would like to hear from the glaucoma colleagues about the NEMO, about using the NEMO, the NEMO, the shots, the shots, or the air buff, like what they're trying to introduce in the academy this year to monitor the IB progression, since this is number 2 for us, a hot item, the glaucoma and the complication management. What do you think?
I think that first, with the glaucoma people, well, all of them left already, is that they...
Yeah, we have medical staff meeting
Okay.
at 3:30, that's why.
Well, okay. I think that the main idea here is that no patient can go to the OR without being evaluated by glaucoma. We have to find a way to have the glaucoma people to see these patients in a short period of time.
Yes.
Because sometimes you send the patients and you will see the patients.
We have Dr. Ahmed. Could you please reply to this? Yeah.
Yeah, and so we need to really expedite the time between our consultation, the evaluation by glaucoma,
Yes.
and the time of surgery.
Okay.
So no patient should be going to the OR without evaluation by glaucoma, and no patient should go to the OR without a previous valve or a previous glaucoma treatment or at the time of the K-Pro implantation.
Yeah. Tony Altafi, who published the largest or the longest follow-up in the world, which is 10 years for the Boston K-Pro, he always request the glaucoma surgeon to do Ahmed implant at the same time. So can we hear from Dr. Samir? It's a must for him.
So I
at
think,
the same time.
I think
Or prior.
all these patients you have to treat as glaucoma suspects, right?
Yeah.
So if they've never had glaucoma, K-Pro is a good way to make sure that they're going to get glaucoma in their lifetime.
That's right.
So my teaching and my training, everyone got a valve. Ahmed valve in every case for K-Pro. And we would actually prefer to do it before the K-Pro surgery, if possible. And then you stage it. Once they're stable, then you have the K-Pro with the tube there. If you need to trim it or if you need to do something, it's easier. Coordinating combined surgeries is difficult. You may have someone on call, maybe not as comfortable with doing the implant at the same time, and then the patient gets discouraged.
Yes.
So combined is good, but it's better if you can have the pressure, especially pre-existing glaucoma. I think having the valve, ahead of time, and actually even a larger valve if they have moderate disease. Because with the Ahmed valve, once you get the K-Pro, you lose your pressure, monitoring ability. And the tonal finger, as you alluded to, is the best that we have. You can do pneumo. You didn't mention that. You can do pneumotonometry at the limbus. We do all of these and then take a guesstimate as far as the pressure. And you can't get too low.
What about the air buff? It was described in the academy. Just do it over the sclera and then do it while patient looking up and, at the periphery.
Unless you have cannulated the AC and can check the real pressure in the eye at the same time, it's almost impossible to know which is the gold standard, because after the K-Pro is done, you've lost all reliable measurements.
Yeah.
And the
Totally
contact
agree.
lens with the sensor, IOP detection.
You have
would
to compare
work
it
for
against
us?
something.
Is it something that we can replace, or still it's not available commercially? The
Again,
contact lens with the sensor.
I think
IOP
that has
test.
some merit, but again, we don't have you lose your gold standard for comparison. So unless you can, intra-op have a manometer and correlate, it's very difficult.
As they were able to put the way to control the intraocular pressure, to measure the intraocular pressure with a contact lens, I think that is not very far that they will design a device to be inside the keratoprosthesis to measure the intraocular pressure.
Yeah.
That's right.
Yeah, because the contact lens is already available in the,
But
studies
I
are
don't
working.
I don't have any idea.
Yeah, but not commercially, yeah.
No
In
commercial.
some part, yeah. in
I
the
have one
States, yeah.
question
We
for
have
Dr.
questions?
Ahmad.
Yeah,
Okay.
thank you,
We'll
Dr.
take
Vargas, for
Uzario
this very
and,
interesting talk.
Correct.
K-Pro is really a very fascinating surgery thing to offer to the patient. Technically, it's not challenging at all. Very simple to do, compared even to phacoemulsification. But I think I have to disagree with you in broadening the spectrum for cases that we can do K-Pro for. Yes, we come across patients that we feel sad for them, especially OCP patients and Stephen Johnson patients. But those patients usually have bony, dry eyes, like bone, really. And even if you do keratoplasty, BKB, they can enjoy vision for some time, and then ultimately they lose it. And maybe losing the vision with a graft that the body heals to is better than losing the vision with a K-Pro, because usually the body never heals over a K-Pro. And an eye with a K-Pro is a permanently open globe, no matter what you do. Whether you put a contact lens, whether you put amnion, whatever you put on the eye, the body can never integrate into the artificial thing that you placed on the eye. We have been in this hospital for a very long time, and we come across patients who had keratoprosthesis for Stephen Johnson or for OCP. And actually, by doing this surgery, you put the patient into I don't know if I can say a false hope, because immediately the patient sees well. Next day the patient can see 20/80 or 20, even 20/20. We saw patients who were able to see 20/20. But once they drift and start having the melt around the capital, then there is nothing you can do. We did a lot of repeated amniotic membranes, glue, conjunctiva, but they kept drifting, and then you have to explant the capro, either fit it in another graft and repeat the same thing again, or put a graft and hope that the eye just closes. Your surgery is just 1 month, but I don't want really to be gloomy in my anticipation, but this patient will not last, the graft will not last with that ocular service. Capro is better is probably good for an eye with good tear film, good lids, blinking is fine. The thing is the long term, is not the short term outcome. The short term outcome can be fine even with a graft, with a BKB. And experience showed actually that most of the capros that we did here, first they don't have good follow-up. The other thing is once they drift, you cannot do anything. Once the patient drifts, you cannot do anything. And the hopeless thing or the worst thing to get is when the patient is having good vision, 20/40, 20/60, and you see in front of your eye that the graft is really melting, and there is a big defect, and the patient gets admitted every now and then with an infection, with a suspicion of endophthalmitis. And I know many patients who had injections, repeated injections for suspected endophthalmitis. And you cannot remove the graft. The patient will go to hand movement. Yeah. You have to keep replacing the graft. If we believe that this is the way of giving them vision, and the patient understands this, then why not? But this is not going to last with the same, no matter what you do. You can suture, you can apply glue, you can apply amnion. Unfortunately, for some patients, it's a gloomy thing.
Yeah, well taken points. So can we move to Dr. Rosario, please?
This is only one question for Dr. Ahmad. It's regarding the MicroPulse CPC. The MicroPulse CPC was approved by the FDA in 2015.
Okay.
We have a lot of experience in Europe for more than 7 years with a good results in Boston Capro in PKP. I know Dr. Ahmad used it before when we have the MicroPulse CPC in the hospital. Yeah. Right now, unfortunately, the machine was only for demonstration.
So is there any really difference?
Yes, with the MicroPulse CPC and Boston Capro and PKP.
And the Ahmed implant, there was a comparison between these two? Yes.
Well, I mean, in general, our experience in the States is MicroPulse CPC, there was a lot of hype when it first came out, and a lot of it, unfortunately, was Iridex trying to phase out their traditional diode units. And really, it's not as exciting as we liked. There's always this happiness in glaucoma for the first 6 months. Anything new, we're excited for 6 months and then a year. Then we tell the people like us with white hair, we say, wait. And then you see they drift back. And a lot of the MicroPulse went on to valve surgery within 6 months to a year. And it's like a watered-down CPC. That's how I can describe it. So I think if you use traditional CPC with milder settings, you're getting a similar titration as you would with a MicroPulse without buying that 30,000, 40,000 unit with the probes that are very expensive. They've really locked people in, to the probe. So that's the long and short.
Okay.
You see in this MicroPulse CPC maybe for this kind of patient is worthy?
So in Capro, I haven't had experience with MicroPulse and Capro, but I think it's the same analogy. With these eyes with bad conjunctiva, you don't want to put a plate. Whether you do a traditional diode and just water down the stats, I think it's just going to be the same long term.
Okay. Good. Okay,
if there's no conj, then ECP, I think it's reasonable to try.
I see.
But you still have to have
ECP, not MicroPulse.
Yeah, ECP, if you have no conj at all.
Okay. Dr. Harbi?
Yeah. Dr. Vargas, you mentioned clearly that the retroprosthetic membrane, the incidence of the retroprosthetic membrane is the same with the BMMA backplate or with the platinum backplate. I think you are pointing to the paper published in the Cornea this year. While this paper is only like 20 to 20 with BMMA, 20 with the backplate.
There's no more patients that.
There is one paper which is in 2011, which is the Gravis expert, clinical expert. It's actually double these numbers, and it shows it's about 78 cases, and it shows that the rate of the BMMA with the rate of the retrostatic membrane is like 41% with the BMMA, while it is only 13% with the platinum backplate. And that one was a multi-centered study, and it is more stronger than this one.
He mentioned it before that the debate is still existent, and he just changed. He removed it temporarily because of the paper. But
yeah, well, whatever I read, either that one
it could be that
is okay, or this one, I still will use the titanium plate. Right? I'm not going to change the way. I'm going to keep using the titanium plate, even if there is paper that said that there is no difference between of the RPM between PMMA and titanium plate.
So the only thing that you listed was the solid. The solid thinks that we have no doubtful data that it will prevent the occurrence of these membranes, right? So that's why you just removed the titanium temporarily because of existing.
Because of this, is this group of, I strongly believe that the group with Jose de la Cruz, Jean-Marie Pereira, all these people,
yes.
Aldave is there. It's a big group of Victor Perez. This is a big group all around the world. And now they're thinking that this is not going to be any difference between PMMM and titanium in the sense of the RPM.
Good.
But I still use it. All my requests will be with titanium. I'm not going to change an old car for a new car. I'm going to keep using the new car.
Yeah. Thank you so much, Phil, because of the lack of the time, and we have medical staff meeting starting soon. If any questions, we can please
you can send me an email.
Dr. Vargas, send him an email. Yes, he's very busy surgeon. Thank you.
كبرت الشاشة
نشيل تبينا نشيل العرض
medical staff. Look for medical staff. Where's the medical staff? Yeah.
It has the agenda and the PowerPoint.
And even the department. Remove the department, please. Yeah, remove these three, these four, including,
Remove.
This is only for Dr. Mesfer, yeah. Go to, no, did you delete? Transfer to with the two departments previously.
Okay. This four.
Yeah, because this is only
Cut
for Dr.
them.
Mesfer. Yeah. A laboratory there is already. So you can delete that. There is. Doctor, this is the election result. This is your agenda.
Okay.
Okay?
Is it here in the?
It's already there? No,
Yeah.
we did not.
Not here.
Here. So we can remove.
This is the one.
Yeah, this one.
Could I close this?
Yeah. That's your USB.
This is the agenda.
Yeah.
Is the election results?
This is the election result. One more. Research for Dr.
How
BB.
it looks like. Good. We need to switch. I have to minimize.
Don't open this
Okay.
one first, huh?
And this is the one.
Yeah.
Okay. I'll put it here. Doesn't stay.
Remove this one. One more research. For research. Dr. Messer. Oh, where's this one? Which one? This is Dr. DB. Where's Dr. DB? There's no retina.
This one?
Oh yeah, maybe this one, December 5. Okay.
That's it.
Yeah, only one for Dr. D. Can we check that one? Can we check everything is there? DID, laboratory nursing, or MED research. Do you have this? Okay. Thank you.
هذا for presentations.
بس كيف الهيطة اللي فلاش
آخر سلايد اللي قبل الأخير.
بحطه نفس الفولدر.
أيوة، حطها كده كويس.